everyone. Welcome to Women's South Asian Federation of Endocrine Societies Clinics, which we started in March last year. So you know that SAFES has 5 countries in its fold. So alphabetically, it's Bangladesh, India, Nepal, Pakistan, and Sri Lanka. So alphabetically, we started this and we're in the second round now. We've already covered topics and we're doing these meetings quarterly. We are doing these meetings with different topics. So far, we've covered PCOS, bone health, obesity, thyroid disorders in pregnancy, pubertal disorders, premenopause, perimenopause. And now today we are going to be talking about, so I'm sure everybody is excited for today's session, which is on pituitary disorders. So Dr. Faria Afsana is with us. She's the president of SAFES. So she will be taking over my place right now. And I'm very, very happy that the institute that has organized this meeting, we have the head of the department with us, Dr. Uma Sekia, and she is the host for today. Thank you. Uma, I cannot thank you enough because we've been working almost for the last 3 months trying to coordinate this. So I hope you enjoy today's session. Over to you, Faria.
Thank you, madam. Thank you for inviting me in this session. And actually, we all know that this women surface women endocrine clinic is scheduled and successfully held in 3 quarterly. And actually, this is the brainchild of Professor Sarita Bajaj ma'am, and we are just with madam to make the program successful. And in each and every program, as each program is ongoing, at first there is a quiz session, followed by case presentation and panel discussion. So I think this pituitary disorder session, as madam told, today is the pituitary disorder session. And like that of the previous interesting endocrine sessions, it will be a very interesting one. And in this regard, I like to invite Dr. Uma, the convener of today's session, to conduct the session. Thank you.
Thank you, Faria.
Thank you so much, Dr. Faria and Dr. Sarita, for organizing this conference on pituitary disorders and giving us a chance, our institute, a chance to participate in it. We are extremely glad. And so first of all, we start the session with a quiz session as before. And to conduct the quiz, we have with us Dr. Rashi Agarwal, who is an endocrinologist from the Dhirubhai Ambani Institute, Kokilaben Dhirubhai Ambani Institute in Navi Mumbai. She is the author of a chapter on childhood hypothyroidism in the ITS textbook. She is an active participant in quiz competitions right from her school days. Her areas of interest are pediatric and adult endocrinology and women's health. So without wasting much time, I request Dr. Rashi to please start the quiz, live quiz.
Thank you so much, ma'am. Good evening to one and all present. It gives me immense pleasure to host the quiz for today's SAFES Women's Clinic. And at the outset, let me wish everybody a very happy Navratri from India. This is a festival where we celebrate womenhood. And it gives me immense pleasure that we are having a session from India in this month. So without wasting much time, let us go to the rules of the quiz. So there will be 10 questions, which will be multiple choice questions with one right answer. So there are only 4 options to each question with one right answer only. And the winner will be decided by not only the maximum number of right questions, but also at the speed of which the answers have been given. So the one who answers maximum questions correctly in the least possible time will be declared winner at the end of this event. I wish everybody a very happy and joyful quizzing. I think we are ready to start. So the first question is, which among these is not a PIT1 lineage pituitary neuroendocrine tumor? And the options are mammosomatotroph tumor, thyrotroph tumor, acidophil stem cell tumor, and corticotroph trough tumor? I think we can proceed to the next question.
Yes, please.
So, a 36-year-old woman with ACTH-dependent hypercortisolism undergoes inferior petrosal sinus sampling with desmopressin stimulation test, and the results of which are displayed on the screen. The MRI shows a left-sided pituitary lesion. Which of the following is the most likely explanation for the values obtained on inferior petrosal sinus sampling? Option A, true right-sided corticotroph microadenoma, true left-sided corticotroph microadenoma with anomalous venous drainage, midline corticotroph adenoma, or an ectopic ACTH secretion. Question 3. Which of the following MRI technique has recently shown greatest improvement in differentiating left cleft cysts from cystic pituitary adenoma? The options are T1 weighted spin echo with gadolinium contrast, diffusion weighted imaging, or option C, that is susceptibility weighted imaging, option D, arterial spin labeling. We can proceed to the next question, please. In immune checkpoint inhibitor induced hypophysitis, which pituitary hormone deficiency is most commonly encountered and which is most commonly preceded by others? Option A, ACTH deficiency, option B, PSH deficiency, option C, growth hormone deficiency, and option D, LHFSH deficiency. I think it was too quick to change the question. We can move to the next question now. In the evaluation of suspected Cushing's disease, recent advances in functional imaging include which of the following traces of PET scan? Option A, 18-fluorodopa scan. Option B, 18-fluoro-FDG PET scan. Option C, gallium dotatate scan. Or option D, that is 11C methionine scan. We can proceed to the next question, please. A patient with long-standing partial central diabetes insipidus is admitted with sepsis and develops confusion, and her serum sodium is 124 millimoles per liter. What is the most likely reason for hyponatremia in this patient? A, cerebral salt wasting. B, SIADH due to sepsis. C, over replacement with desmopressin and excess free water intake. Option D, increased renal sodium loss. We can now proceed to the next question. In patients on pegvisomant therapy for acromegaly, which of the following requires most frequent monitoring? Option A, growth hormone levels. Option B, insulin-like growth factor 1 levels. Option C, liver function test. Or option D, MRI for tumor size. We can now proceed to the next question. A woman with microprolactinoma desires pregnancy. She is on cabergoline 0.5 milligrams per week with normalized prolactin and regular cycles. What is the best management approach? Option A, continue cabergoline throughout pregnancy. Option B, discontinue cabergoline once pregnancy is confirmed. Option C, switch to bromocriptine during pregnancy. And option D, perform prophylactic surgery before conception. We can now proceed to the next question. Which of the following is an emerging biomarker in cerebrospinal fluid under investigation as a diagnostic tool for autoimmune hypophysitis? Option A, elevated CSF neurofilament light chain. Option B, intrathecal antipituitary antibodies. Option C, increased CSF amyloid beta. Option D, elevated tau protein. We can now proceed to the last question for this session. A 16-year-old boy presents with short stature, delayed puberty, history of neonatal hypoglycemia. His labs are suggestive of panhypopituitarism. An MRI brain is suggestive of hypoplastic anterior pituitary, ectopic posterior pituitary bispot, and thin and absent pituitary stalk. Which among these following statements is true? Patients typically have isolated growth hormone deficiency with preserved other pituitary axis. Option B, posterior pituitary hormone secretion is usually absent, requiring lifelong desmopressin therapy. Option C, genetic mutation in PROP1, HEX1, LHX4 has been implicated in familial cases. Option D, growth hormone therapy is contraindicated due to high risk of tumorigenesis in this syndrome. Since we have 2 more minutes, I would request the tech team to quickly pass through all the questions once more.
No, I think we'll go ahead. That's okay.
Okay, ma'am.
I don't think we need to repeat them, please.
Okay, ma'am.
Because sometimes the cases take longer, right?
Okay, ma'am. Yes, ma'am.
Over to you, Uma. Thank you, Rashi.
Thank you, Rashi.
Thank you, ma'am. Thank you so much.
So we go on to our first case presentation. And to chair this session, this case, we have Dr. Faria Afsana. So I invite Dr. Faria to take over and invite the moderators and the panelists for the session and the case presentation.
Thank you. Thank you. In this time, I like to start the first case discussion, and the case presenter will present the case, and the moderator is Dr. Jethwani, Parth Jethwani, and I will request him to start the session.
All right. Thank you so much, ma'am. So without wasting further time,
I'm so sorry to interrupt. Amit, don't we have the CV slides? Amit? Yeah, I think those, Amit, I think this is a usual procedure, please.
Okay, let me introduce.
Thank you. Yeah.
Introduce the moderator, and he is a candidate for best outgoing resident in Department of Internal Medicine, and got the gold medal award, the Dr. Shankar Dayal Sharma Gold Medal Award, best outgoing candidate, and he is he hold the first place in the ISBMR quiz and poster presentation 2022, and he got the India Sweden Healthcare Innovation Award 2022-23, And he had multiple papers in international and national journals on endocrine research and clinical practice with many citations, and presented many conferences in papers in conferences too. So let's start with Dr. Parth Chitwani, please.
Great. Thank you so much, ma'am. I would also request you to please put out CV slides of the expert panelists, Dr. Ruma ma'am and Dr. Amit sir. So I'll just read them out.
Yes, please. Yes, please.
Request the tech team to please put out the CV slides.
Thank you. Thank you.
Yeah, so we have two panelists for this interesting case today that we'll be discussing. So we have Dr. Ruma ma'am, which we have already discussed about. She's currently the professor of endocrinology at Guwahati Medical College. She's also the president, Northeast affiliate of Endocrine Society of India, and her areas of interest are reproductive endocrinology and thyroid disorders. She has a multitude of publications, more than 15 national and international journals. Welcome, ma'am, and we look forward to this interesting case discussion. Dr. Amit sir as well.
Thank you very much.
Right. We also have Dr. Amit Shakya sir with us. So, sir is currently the medical director at RS Lifestyle Hospital, Kathmandu, Nepal. He's also the president and one of the founders of DEAN, that is the Diabetes Endocrinology Association of Nepal. So, we have two excellent panelists with us. And most importantly, I would like to invite the presenter for today, that is Dr. Surya Narayan Jina. And he will be presenting a very, very interesting case that we'll sort of discuss back and forth. So I now invite him to start with the case presentation. So he's currently in his third year at Guwahati Medical College.
Go ahead.
You can load the slides. Scrub.
Good evening, everyone. Are my slides visible?
Not yet. Yeah. We want slideshow.
Good evening, everyone. I will present the first case of central diabetes insipidus. A 43-year-old lady, a homemaker from Assam, presented with chief complaints with polyuria polydipsia for 7 months duration, headache for 7 months duration. Coming to elaborating the history of present illness, history of polyuria polydipsia for last 7 months with total water intake roughly 10 to 12 liters per day and preference for cold water. History of headache for 7 months duration, mostly in the frontal region, mild to moderate in intensity, last for 30 minutes to 2 hours. For episodes, 1 to 2 episodes per month, subsides with or without NSAIDs. And history of generalized weakness with easy fatigability are also present. But there is no history of any polyphagia, weight loss, dysuria, fever, suggestive of diabetes mellitus with recurrent UTI. No history of any renal stones, bony deformity, fracture, or any obstructive uropathy symptoms like poor urinary stream. No history of any vomiting, visual disturbances, loss of consciousness, seizure. No history suggestive of constipation, cold intolerance, or weight gain or hypothyroidism. And no history of any nausea, vomiting, pain abdomen, diarrhea, postural dizziness, suggestive of adrenal insufficiency. No history of galactorrhea or acral enlargement. Then there was no history of fever, chronic cough, hemoptysis. Also, no history of any drug intake like SSRI, tricyclic antidepressants, lithium, or diuretics use. Past history, there was no history of any diabetes mellitus, hypertension, tuberculosis, or any thyroid illness in past. No family history of diabetes mellitus or any intracranial tumors. Menstrual history, she is having regular menstrual cycles. Coming to general examination, patient is conscious, cooperative, BMI of 22.7 kg per meter square. Pulse rate was 76 per minute regular, and blood pressure was normotensive 128 mm mercury without any postural drop. However, there is presence of mild dehydration without any pallor, icterus, cyanosis, clubbing, pedaledema. JBP is not raised. Thyroid gland is normally palpable without any mucosal hyperpigmentation, no signs of insulin resistance, and normal SMR status B5, P5, no galactoria and axillary hairs present. Coming to CNS examination, visual acuity is 6/9 in both eyes. Visual field is normal in confrontation method. Fundus is normal. Extraocular movements are normal. Rest CNS examination is normal. CBS, no precordial bulging. Heart sounds are normal audible. No murmur. Respiratory system examination also. Trachea central. Normal bilateral vesicular breath sounds without any added sounds. For abdomen examination, umbilicus is central. Abdomen is soft, non-tender, no organomegaly. On quantification, urine output is 11 liter per day, which is 215 ml per kg per day, and intake is also 12 liter per day. Then coming
Right.
to investigations.
Can I just sort of stop you here, Dr. Suryanarayan? Just a couple of
Okay,
questions that I had before we move on to the lab part. So we have covered the history and examination. You have already highlighted in your introduction that it's a case of diabetes insipidus, and you mentioned about the history of renal stones that you did ask. So can you just sequentially let us know as to specifically when we are looking at diabetes insipidus, why did you ask the history of renal stones and any obstructive symptoms that we should rule out? So, why did you go about asking that history, and how did you sequentially rule out etiologies, possible etiologies of diabetes insipidus?
Sir, in case of some patients of nephrogenic diabetes insipidus also presented with obstructive uropathy, and some hypercalcemia cases also will have polyuria. So for that we have to rule out renal stones. They may be presented with pathological fracture or any bony deformity. And renal tubular acidosis also sometimes presented with polyuria. For that, we
Right.
have to ask for any renal stone, nephrocalcinosis, or any obstructive uropathy symptoms. Also, in long term, they will lead to polyuria by obstruction causing the destruction of the collecting duct that will cause vasopressin resistance. So they will present with nephrogenic deficiency.
Right. Excellent. Any other electrolyte that you're looking at besides calcium?
Mostly hypokalemia also sometimes presented with long-term hypokalemia also presented with diabetes insipidus.
Right. Excellent. I think you can go ahead.
Coming to investigations, the hemoglobin is 8.2 on routine investigation. TLC was 6,320. Creatinine was normal, 0.5 milligram per deciliter. Their sodium is 142 millimole per liter, and calcium is 8.5 milligram per deciliter with phosphorus of 4 milligram per deciliter. And liver function test shows normal, and fasting blood pressure and postprandial is normal, normoglycemic status. And urine osmolality is 62 milliosmol per kg, and serum osmolality is 284 milliosmol per kg. Urine showing normal examination without any investigation suggestive of UTI. And potassium is also 4.5 millimole per liter. Then coming to next anti-peptide profile, showing normal thyroid status, TSH of 2.99 microinternational unit per ml with T4 normal 118.3 nanomole per liter. Cortisol is 2.81 microgram per deciliter with prolactin 50 nanogram per ml, and ACTH is 6 picogram per ml. IGF-1 is 146 nanogram per ml with FSH of 12 milliintestinal unit per ml, suggestive of secondary adrenal insufficiency with hyperprolactinemia. Then when we move towards water deprivation test, after this anti-peptide profile, polyuria is confirmed. So we move towards water deprivation test. At the starting of test, patient's baseline sodium was 141, weight was 50.4 kg, urine osmolarity was 62.04, and serum osmolarity was 288.5. We continue the test for 4 hours. After 4 hours, She had sodium of 149 and serum osmolality 305 millismol per kg. Urine osmolality is 108 and body weight is 47.3, which is 6% body weight loss. So we stopped that water deprivation test at 4 hours as sodium is more than 149 and body weight loss is also 6%. So we give vasopressin injection after the dehydration phase. We give vasopressin 5 intestinal units subcutaneously. Then we monitor for urine osmolality and urine output for 2 hours. In the first hour, urine osmolality is 337 millismol per kg, and in the second hour, it is 325 millismol per kg with urine output of 100 ml in the first hour and 40 ml in the second hour. That suggests urine osmolality was increased more than 200% after vasopressin, suggestive of central diabetes insipidus from 108 to 325 millismol per kg. Then we proceed with MRI for this to rule out any intracranial space occupying lesion. MRI, T1 weighted MRI, sagittal section showing pituitary gland of normal size that measures 11.5 into 4.5 into 8.5 mm. Pituitary stalk appears thickened, pointed by the red arrow, measuring 4.2 mm just above the gland and 2.5 mm at the level of optic chiasma. There is absence of postpituitary bright spot. However, on the dynamic imaging, the gland reveals contrast enhancement in the expected pattern without any non-enhancing hypointensive focus. Impression of the MRI, hypophysitis. Then we rule out other causes of hypophysitis. For that, we did CSF analysis. CSF analysis showing normal cell count of 3 cells per mm, and all are lymphocytes. Glucose and protein are in the normal range. For tuberculosis, we did gram stain and CB0 and AB stain, all are negative. ADA is also in the normal range. To rule out other causes of hypophysitis and autoimmune causes, we did ANA, which was negative, but anti-TPO was positive, 44.85, and repulsion upper lab is 34. C-ANCA, P-ANCA were negative. Serum SC in the normal range, 34 unit per liter, and serum IgG4 was also in the normal range, 0.5. Montoux test we did and chest X-ray, that are all normal. So we came to a final diagnosis of central diabetes insipidus, newer terminology like ABP deficiency. Most probable etiology secondary to lymphocytic hypophysitis with secondary adrenal insufficiency.
Right. If I can just ask you to go a little back over here and include Uma ma'am in the discussion. So, ma'am, if you can just sort of let us know how do we go about doing the water deprivation test, and in terms of interpretation of the water deprivation test, in terms of, at times there is a lot of confusion specifically with a partial DI. I think primary polydipsia is relatively straightforward, but when we're looking at partial forms of DI, so the first part of the question being, how do we go about doing a water deprivation test to make it easier for the audience, and then sort of how do we go about interpreting it?
So the water deprivation test is, though we've been using this for several years, it's sort of taken as the gold standard, but we all know that it has its fallacies and it's a cumbersome test. So if the patient is having severe polyuria, as in this case, we would not like to start the water deprivation overnight. We would like to start it in the morning itself. But say patients who are having milder degrees of polyuria, we can do it from the night itself. We can restrict fluids from night. So in this patient with severe degree of polyuria, so we ask the patient to void in the morning, and then she starts fasting. There is no water intake. The patient is to be monitored to see that, she doesn't drink water in between. And very important, check the body weight, the blood pressure, any, signs of dehydration, whether she's become restless or not. So she has to be monitored. And then we measure the plasma osmolality, the serum sodium, and the urine output and urine osmolality. And ideally, this is to be done hourly. But again, there are practical problems. Measuring serum osmolality every hour, at least in many centers, it becomes an issue. So, we may have to do it every, say, maybe 2 hourly. Then how do we terminate the test? So if the serum sodium rises with the severe hypernatremia more than 145, or if there is more than 3% of body weight loss, or if the patient, becomes so restless that, she's not able to stop the, that extreme craving for water. And the rise of, what should I say, and severe hypotension. So these are the things, especially postural hypotension. So then we would prefer to terminate the test. And once the test is terminated, the patient is then given vasopressin. And from this time on, the patient can be allowed to take fluids as well as the, normal oral intake is allowed. And then again, after giving vasopressin, we see the response to vasopressin at every hour, the urine, especially the urine osmolality and the urine output. Now, classically, if it's a complete central DI or a complete nephrogenic DI, it's quite straightforward, because the there will be, the urine osmolality will not rise much with dehydration. And once you give vasopressin, there will be more than 50% rise in a complete central DI. And in a nephrogenic DI, it will be less than 50%. The problem arises when there is, over primary polydipsia, or if there is partial central DI or a partial nephrogenic DI, then there is so much of overlap between these values. And it's also seen that these are the fallacies of the water deprivation test. So it's seen that in patients who have had untreated central DI for a very long time, in them, the aquaporin channels are downregulated. So that even if we give vasopressin, we may not get the expected response. That is more than 50% response. And then we may label the patient as, primary polydipsia or a nephrogenic DI. That is one fallacy. Similarly, in cases of primary polydipsia, because there is already a volume overload, that volume overload will not cause sufficient AVP secretion. So that again, we get a picture which is overlapping with central DI. And again, in long-standing nephrogenic DI also, because of this, you may not get a clear response. So that's why there are nowadays the newer methods to overcome these overlapping features. The value of copeptin is being, it is being either basal copeptin levels or stimulated copeptin levels, which may give a better, help us to decide better.
Right. Excellent, ma'am. I think you have made it very easy for all of us in terms of protocol and also in terms of interpreting results and taking this forward from here where you ended the copeptin levels. I'll now sort of include Dr. Amit sir into this. So copeptin levels have come up a lot these days. Also, we are not doing it a lot practically, but I think their levels have a higher sort of sensitivity, specificity specifically with so many fallacies of the water deprivation test. So we are doing basal copeptin and stimulated, as in hypertonic saline or arginine stimulated copeptin levels. So if you can just shed some light on that as to how do we do that? What is the basis for that? And how do we sort of interpret the values?
Thank you. Thank you for the question. As ma'am has already told that water deprivation test is a little bit of cumbersome and it takes time for the patient. And for that, a new test has become a game changer. It's a copeptin level to test, and it's absolutely diagnosis for diabetes insipidus has changed. And in many centers, it's replacing the classic water deprivation test right now, but it's not widely available in the big center like that, because it's also not a cheapest one to test. So those who can test, or those in the center which is available, then of course it is very reliable and safer test to do. So actually, copeptin is the C-terminal part of the provasopressin. So it's a provasopressin. It's a C-terminal part, and it secretes equimolarly with vasopressin also. And it is a very stable surrogate marker for vasopressin secretion. And it is easier to measure compared to arginine vasopressin, which is unstable and difficult for the assay. And there are, yes, as rightly told, it's two main strategies to do that. One is baseline, that is unstimulated copeptin. And there is another one, stimulated copeptine. So like in water deprivation test, like we do without vasopressin stimulation and with vasopressin stimulation, same like that, but a little bit is different, because in baseline, it's very good that if the baseline copeptine is high, the actual value is, I think, around 22 picomole per liter. If we found that the baseline copeptine is more than 22, with hypotonic polyuria, then it is nephrogenic diabetic insipidus, because copeptine secretion is intact, but kidney is not responding to the copeptine or argan vasopressin. So we can say that it is nephrogenic diabetes insipidus. If copeptine level is low, I think in the literature it has been told that it's less than 2.6 or something like that. If it is less than 2.6 picomole per liter with hypernatremia or hyperosmolarity, then it is suggestive of central diabetes insipidus. But if value are intermediate, then we need to go for further test, that is stimulation test. So what in the stimulation test is the most it's widely valid. It is most widely validated approach, and stimulation by giving 3% hypertonic normal saline in NaCl until plasma sodium rises to more than 147 millimole per liter, or plasma osmolarity more than 295. So at that time, when sodium reaches more than 147, copeptine is measured and taken at the point, and interpretation will be if the level of stimulated copeptine is less than 4.9 picomole per liter, then it suggests central diabetes insipidus. If more than 4.9 picomole liter, then it suggests primary polydipsia, because it means there is a normal vasopressin response or copeptine response. So advantage is that it is more accurate than water deprivation test. It is faster, because in water deprivation test we need maybe a whole night or at least 6 to 12 hours. But in copeptine test, it is done within 2-3 hours, and it is better tolerated by the patient and easy for the physician to check anytime. No need for prolonged dehydration also. So it is less prone to interpretation pitfall, like partial diabetic insipidus, medullary washout, because if you see the level straightforward without any stimulation, baseline is high, then you can rightly say it is nephrogenic diabetic insipidus. So if not nephrogenic, then we move to the stimulated test of copeptine with hypotension, as I've already told. So I think, and this test is rightly said that it can differentiate between central diabetic insipidus and polydipsia with accuracy of, I think, more than 95%. But it is not widely available. In Nepal also, it is very rare. In the 1 to 2 only center it is done, because it is expensive also. But I think in near future, it will replace the water deprivation test. Thank you.
So I think Sir has excellently put it across that yes, copeptine is possibly the future, specifically when we are looking at a test which has a lot of fallacies. And if I have to just put it across simply for the audience, so you basically are looking at 4 values. One is non-stimulated values, which are around 21.4, like Sir said, around 22, and less than 2.6. If the values are less than 2.6, you are essentially looking at the central diabetes insipidus. More than 21.4 or more than around 21 or more than 22, then you are essentially looking at nephrogenic DI. And if they are intermediate, you stimulate it with hypertonic saline. And if the values are less than or more than 4.9, then you will differentiate it between primary polydipsia and DI. So this is how we go about it, and it is possibly the future. So we need to sort of look at this. And if I'll now request Dr. Suryanarayan to just go back to the previous slide, because MRI is something which is very critical, specifically when we are looking at a DI or even hypophysitis. So we see a wonderfully thickened stalk. So first, if Dr. Suryanarayan, I can just ask you to highlight how do we diagnose specifically in terms of dimensions a thickened pituitary stalk? What are the values that we are looking at?
Sir, pituitary stalk is up to 4 mm just above the gland, and up 2 mm at the level of optic chiasma, that is normal. Less than 2 mm and more than 4 mm, less than 4 mm. At the gland 4 mm and at the level of optic chiasma 4 mm. If it is more than that, we call the stalk is thickened.
Right. So if now I can move forward and bring Dr. Uma ma'am into this. So ma'am, very often we have a thickened pituitary stalk in the MRI, and if not taking the history into account in this case, if we are specifically looking at a thickened pituitary stalk, what are the possible differentials that we are looking at, and then how do we differentiate them from those differentials, the common ones?
So basically, when we get a thickened pituitary stalk, we think that yes, this is probably a hypophysitis. So when we say hypophysitis, this is generally an umbrella term which embraces different conditions. So it is an inflammation of the pituitary. So if it involves only the anterior pituitary, it is an adenohypophysitis. If it involves the stalk with the posterior pituitary, it is an infundibulo neurohypophysitis, or it could be a panhypophysitis. So when we think of conditions which can cause this, so we can divide it into primary and secondary causes. Now, in the primary conditions which can lead to a thickened pituitary stalk, the most common is autoimmune hypophysitis, that is lymphocytic hypophysitis, or a granulomatous hypophysitis. And we have so many other secondary conditions. Now, among the secondary conditions, the drug-induced hypophysitis, this is coming as a major cause, most commonly the immune checkpoint inhibitors. Then we have the other autoimmune conditions like type 1 diabetes, or even thyroid, Hashimoto's disease, or they may be having some other autoimmune conditions like SLE or Sjogren syndrome. So these are secondary causes which can also involve the pituitary. Then we have Langerhans histiocytosis infiltrations. Other infiltrations like tuberculosis, sarcoidosis, these also have to be taken. We should keep this in mind and then take the history and think about it. Then another very important thing is that other than hypophysitis, there is often a confusion that is this, suppose only the gland is enlarged, you get a bulky pituitary, whether this is a pituitary adenoma or not. So then there are some differentiating points, whether this is more in favor of a hypophysitis, or is it a macroadenoma of the pituitary, a non-functioning macroadenoma. So there is one scoring system which is called the Gutenberg system score, which basically takes into account certain clinical parameters and some MRI findings. So the clinical parameters which are taken are the age of the patient. The age less than 30 years favors hypophysitis more, or if it is associated with pregnancy, say during pregnancy or in the postpartum period, that is again more in favor of a hypophysitis. Then if we see the MRI findings, like one is if the stalk thickening is there, absence of the pituitary bright spot, posterior pituitary bright spot, increase of the pituitary volume more than 6 cc, or if there is what should I say? It's a homogeneous enhancement. When you give gadolinium, a homogeneous enhancement. These are factors which go in favor of a hypophysitis. Whereas if you get an asymmetric enlargement of the pituitary, or if there is what should I say? The posterior pituitary bright spot, we are seeing that. Then, and if the enhancement is heterogeneous rather than homogeneous, these probably go more in favor of a pituitary adenoma. And another sign which is also described is the mucosal thickening of the sphenoid sinus. That indicates that there is some inflammation in the pituitary region. That again is in favor of a hypophysitis. So if the score, there are different points given for each of these. And if it goes towards negative side, less than 0, that is in favor of a hypophysitis. Whereas if it is in the positive side, it's more in favor of a pituitary adenoma. So this is one of the differential diagnosis. Other certain lesions in the cellular supracellular region like germinomas can cause confusion. But then germinomas, usually they are more common in younger age group in males. But if we suspect, then of course we will have to do investigations for alpha fetoprotein or beta HCG to look for rule out germinomas. So I think there is such a wide range of conditions which we have to keep in mind and proceed depending upon the clinical scenario of the patient.
Right. So, ma'am has very extensively put it across on how to go about looking at the thickened pituitary stalk. And I think one of the major key takeaways for the people listening is that whenever you're looking at a thickened pituitary stalk, we by default at times to tend to think we are looking at a hypophysitis, which might not always be the case. So, you might be dealing with possibly a non-functioning pituitary adenoma, and you have to then look at the type of enhancement, the size of the pituitary, the age, if the female is pregnant or not, these sort of factors to weigh in if it's a hypophysitis or a non-functioning adenoma, and then go about delineating the etiologies of each of them. So now, ma'am had highlighted about the posterior pituitary bright spot, which is very often, taken to be absent in diabetes insipidus. I'll now want to bring Dr. Amit sir into this. Sir, is the posterior pituitary bright spot always absent in a DI, central DI specifically, and how sensitive and specific is it? Is it absent in normal individuals also at times? So, how can you just highlight a bit on the posterior pituitary bright spot? So you have to unmute yourself.
Sorry. So,
Yes.
posterior pituitary bright spot on MRI is actually highly specific, around 90 to 95% for central diabetes insipidus, because it's caused by disruptions of or damage to the posterior pituitary, such as due to Sheehan syndrome or due to pituitary tumors or after surgery or any kind of radiation in the head, and any damage to be done on hypothalamic pituitary tract. Uh, but the sensitivity varies depend on the cause of the diabetes insipidus, because in fact in also in partial central diabetes insipidus, due to partial pituitary damage, for instance due to mild sarcoidosis or lymphoma, then bright spot might still be visible due to residual vasopressin release capacity. And in primary polydipsia also, even if the absence of bright spot suggests central diabetes insipidus, it can sometimes occur in patients who have primary polydipsia due to excess water intoxication, because they suppress vasopressin secretion unnecessarily through volume overload. So there are technical factors also, like due to poor image quality or incorrect MRI sequence may lead to a false negative result. And some condition like even in diabetic mellitus also, and in microcephaly, bright spot may also be not so good visible. And they are, of course, not unrelated to diabetes insipidus. So that's why the diagnosis relies more heavily on dynamic tests like water deprivation test, and as I already told, copeptin test for to diagnose central diabetes insipidus. And when combined with clinical features and MRI features, then we can then go for the right diagnosis. But MRI alone, it cannot be diagnosed, because as ma'am also told, there are lots of falsies are there. We should look out for the other tests also, like I've told, copeptin or water deprivation test.
Right. Excellent, sir. So, I mean, we have pretty much summarized the imaging and the water deprivation test, and we sort of now do have the diagnosis with us in terms of, it being a central diabetes insipidus with a secondary adrenal insufficiency, like you highlighted. So now I'll request Dr. Suryanarayan to move forward as to how did you go about managing this case?
Then we treat her with prednisolone as patient is having secondary adrenal insufficiency. So we start with prednisolone 40 milligram per day, once daily after breakfast. We continue for 1 month. Then we gradually taper the prednisolone in the subsequent next 1 month. So total prednisolone she received for 2 months duration. In the meantime, also we started desmopressin 0.1 milligram daily at bedtime. That is 6 days in a week with 1 day off, and adjusted according to input output. And we monitor the symptoms and electrolytes, specifically serum sodium during that time. Then we gradually titrated the desmopressin dose and increased to 0.1 milligram twice daily in the morning 8 a.m. and at the bedtime with 1 day gap and 6 days per week. Then subsequently, we follow the patients. After 6 months, we repeated the anti-pituitary profile, and patients had also symptoms of adrenal insufficiency symptoms. They are not present, but patient have polyuria. Whenever she misses the tablet of desmopressin, she has polyuria around 6 to 7 liters per day. On the day of tablet, and urine output reduced to around 2 to 2.5 liters per day. An anti-pituitary profile, thyroid profile is normal. T4 is 1.44 nanogram per DL with TSH of 4.2 microinterest unit per ml. And cortisol also normalized. 8 cortisol is 9.89 microgram per DL. Prolactin also normalized after 6 months, 8.85 nanogram per ml. And FSS remaining in the same range, 12.5 milliintestinal unit per ml. And sodium is 143 millimole per liter. There is no hyponatremia. Creatinine and potassium are in the normal range with RBS. We repeated the MRI also after 6 months, and we found pituitary stalk was normalized after 6 months. And now the stalk measurement is 2.4 mm at the insertion into the gland and 1.6 mm at the level of optic chiasma with normal pituitary gland, and pituitary bright spot is absent. Currently, patient is doing well. No history of any headache. She is having regular cycles, but there is persistent history of polyuria. So tablet desmopressin was continuing 0.1 milligram twice daily at 8 a.m. in the morning and at bedtime, 6 days in a week with 1 day gap. Whenever she misses the tablet, she had a history of polyuria. So she is currently continuing desmopressin only. Thank you.
Thank you for that presentation. If I can now move on to Dr. Uma ma'am for the next question. Ma'am, he mentioned that the patient was put on desmopressin tablet, and we know that desmopressin is available with us in various forms. We have sprays, we have injectable forms also. So if you can just shed a bit of light on that, and also how do we go about monitoring the patient when he or she is on desmopressin?
So desmopressin, we have tablet forms and we have nasal sprays also. The tablet comes as 0.1 mg tablet. So usually we start with a bedtime dose, but patients who have severe polyuria may require twice daily dosing. And then the response to therapy has to be monitored basically based on symptomatology, how frequently the sleep is disturbed at night, because that is the main problem for most patients. They have to get up several times at night and keep on drinking water at night. So that has to be taken into account. Then the most important thing is that we have to monitor the serum sodium levels, because they may go into dangerous hyponatremia. And we also should ask about any symptoms of hyponatremia, whether they are developing dizziness or some confusion or anorexia. These may be some symptoms of hyponatremia. So basically look at the blood pressure, any signs of fluid retention, any signs or symptoms suggestive of hyponatremia, what is the urine output and what is the intake, whether the polydipsia, polyuria has come down, and then we adjust the doses. It also comes as a nasal spray that gives about 10 microgram is given with one dose. So that has to be, you taken a spray in each nostril. So usually we see that patients are more comfortable with tablets. So most of our patients, we are putting them on tablets. And injectable preparations, only vasopressin is available, so that you just use it for the test, but we don't use it for as a treatment. So either a spray or the tablet, whichever the patient feels more comfortable with, but especially children also, they are more comfortable, parents are more comfortable with giving the tablets.
Right. Thank you, ma'am. So it's basically the sodium levels, the volume status that we are looking at to, adjust the desmopressin dose and timing. And now I'll move on to the last question to Amit sir, that he highlighted that they did a follow-up of the anti-pituitary hormones and the MRI at around 6 months. So, sir, from a long-term perspective, how do we go about monitoring the patient specifically with this imaging and the hormonal workup?
So actually, for central thyroid insipidus, the follow-up is very much important. And because it may be the first sign of evolving pituitary stalk disease, like other diseases like pituitary stalk or even neoplastic tumor inflammatory disease may come afterwards. So the follow-up is very much necessary. So, and not also that, also the pituitary hormone deficiency, like other hormone, even anterior pituitary hormone deficiency may appear later in the course of the disease. And the main thing is imaging changes also may evolve slowly over months. So based on that, I think there are four stages, monitoring stages we have to look for. The first one is clinical and biochemical monitoring, right? So every 3 to 6 months in the first year, then yearly, if stable, we have to check if patient develops any symptom of thirst, urine output problem, is patient adherence to desmopressin, maybe because many of the patient can skip the dose of desmopressin, and is there any hyponatremia risk. So that's why we need to check serum sodium to see risk of both hyper and hyponatremia. Then also we have to check anti-pituitary hormone like ACTS, cortisol, thyroid function test, prolactin, LSFSS, IGF-1 growth hormone, etc. So even if all are normal at baseline, deficiency can appear a month or year later. So we have to recheck regularly. And the second one is MRI follow-up. So at diagnosis, baseline pituitary hypothalamic MRI should be done. And then 3 to 6 months, we can do again to detect progression of stalk thickening, like germinoma or hypophysitis or sarcoidosis may appear. And if not that, then we can repeat MRI after 12 months, that is 1 year. So in long-term perspective, we can repeat the MRI again after 2 years if patient feels fine and there is no other symptom or hormone deficiency develops. So if lesion is stable for 2 years and no symptom occurs during 2 years, then we can go for follow-up and do the MRI after 2 to 3 years. And the third one is if any symptom or emergency occurs, then we have to call the patient and we have to follow up again. If there is any new or worsening pituitary hormone deficiencies or progression of stalk seen in the MRI, like as already told, more than 4 or 5 millimeter, or stalk is getting asymmetric, or any hypothalamic involvement is there. So even then, patient we must check visual changes also, because there may be a visual problem or headache with the patient. And in long-term perspective, then we can go for the MRI after 2 years. And if the patient feels better and patient is stable, then we can do MRI for again after 3 to 5 years. So lifelong follow-up is required. If idiopathic central diabetic insipidus is suspected, then because 30–50% of cases in the future, especially germinoma or sarcoidosis, may develop later in life. So I can say that we must do the baseline test, and after each 3 to 6 months, until 1 to 2 years, we have to see all the hormone panels. Repeat MRI after 1 year, and again in 2 years. So beyond 2 years, I think if patient is good and his parameters are also good, and there is no MRI changes, then we can do 3 to 5 yearly also MRI. So I think this is the long-term perspective and long-term follow-up for central diabetes insipidus.
Right. Thank you so much, sir, for that highlight on how do we go about following up the patient. So it's important to recognize that even after the diagnosis, they might develop other hormone deficiencies. That is why we need to follow them up. And then, of course, we do successive MRIs at yearly intervals and then gradually decrease frequency of the imaging. So with this, we come to the end of this case presentation, and I thank each one of you, Dr. Suryanarayan, Dr. Uma ma'am, Dr. Amit sir, for that excellent discussion on how do we go about diagnosing and managing a case of diabetes insipidus. I now hand it over to Dr. Uma ma'am to take it forward to the next case. Thank you so much.
Thank you, sir. Ma'am.
Thank you.
Thank you, Dr. Parth, for conducting this session so nicely. Now we move on to our second case presentation. For this, I invite Dr. Achini Vijayasinghe. She will be the chairperson for this. Can you please share her? Yes. So Dr. Achini Vijayasinghe, she is a consultant endocrinologist at Teaching Hospital Badula, Sri Lanka. She holds an MD in medicine from University of Colombo and an MRCP in diabetes and endocrinology. She was trained in Sheffield, UK. Her current clinical practice focuses on endocrinology and diabetes at the Teaching Hospital Badula. She is a co-editor of the Sri Lankan Journal of Diabetes, Endocrinology and Metabolism. She has contributed to several national and regional guidelines, including those developed by SAFES and the Sri Lanka College of Endocrinologists. So with these introduction, I request Madam to kindly conduct the session.
Thank you very much, Dr. Uma, for the kind words of introduction. And next in line, we are going to have another very interesting case discussion. And for that, we have three distinguished panelists. I would like to first introduce our first panelist. So the case presentation will be done by Dr. Abhijit Saka. He's a second year student from Guwahati Medical College. And then we have three panelists. First, Dr. Shaurabha Bhatt. She's an associate professor at Department of Endocrinology at Yenipoya Medical College, Bangalore. And she has received many academic achievements and awards, including National Young Academic Excellence Award 2024 by Indian Medical Association. And then we have our next panelist, Dr. Anurag Leela. He's a professor in endocrinology at SETH, GSMC, and KEM Hospital, India. And his areas of interest include pediatric endocrinology and endocrine oncology. And he has multiple publications to his credit. And he has received multiple awards for his research as well. And then third in line, we have Dr. Rujlal Rahman. Can I have, yeah. So she's an associate professor of endocrinology and head of Department of Endocrinology at Jinnah Postgraduate Medical Center, Jinnah Sindh Medical University, Karachi. She's from Pakistan. And she has multiple publications to her credit as well. And her research interest focuses on diabetes, pituitary, thyroid, and disorders of sexual development. So I think I did not all of the three panelists to start the next case discussion. Thank you.
Yes, thank you, Dr. Achini, for that kind introduction. So now I would like to first welcome everybody and invite Dr. Abhijit to present the next interesting case. This will be a relatively shorter case presentation. The time allotted is less, but a very interesting case. Over to you, Dr. Abhijit. Dr. Abhijit is here.
She's there.
Yeah.
He's there, but I think he's just trying to
Please share your slides.
Yes, ma'am. I'm trying to share the slides.
Yeah.
I think we're just seeing your main screen. Yeah, but I think something great. Go ahead.
Is my slides visible, ma'am?
Yes, absolutely. Go ahead.
Okay, ma'am. Good evening, everyone. I'm Dr. Abhijit Sarkar, senior resident, second year, Department of Endocrinology, Guwahati Medical College. I'll be presenting this second case, which is a rare case of pituitary mass. Starting the case, we are presenting a case of a 56-year-old postmenopausal lady who presented to us with chief complaints of headache since last 6 months and progressive visual impairment since last 2 months. Initially, it started in the left eye, then progressed towards the right eye. Elaborating the history of presenting illness, the headache was dull aching in character. It was since last 6 months, initially frontal, then it progressed bitemporally and it was persistent throughout the day and gradually increased in intensity, and it was not relieved by analgesics. She also complained of blurring of vision since last 2 months, which initially started in the left eye, then progressed to involve the right eye within the next 2 weeks. She also complained difficulty reading and recognizing faces, navigating in dim light, and bumping into objects. Okay, continuing the case, she did not give any history of galactorrhea. There was no history of increase in ring size, shoe size, or no worsening of facial features, no hyperhidrosis, no history of weight gain, proximal myopathy, thinning of skin, stria, or mood changes. There was no history of any easy fatigability, weight loss, or postural dizziness. And there was no history of any cold intolerance, weight gain, constipation, or dry skin. and there was no history of polyuria or polydipsia. Coming to her past history, she did not give any history of prior headaches, seizures, CNS infections, trauma, any major surgeries or malignancies. Menstrual and obstetric history, she attained menarche at the age of 12 years and attained menopause at the age of 46 years. And she had regular cycles in between. She had 3 full-term normal deliveries, and there was no history of any abnormal bleeding or hormonal therapy. And she did not have any family history of similar illness. She complained of reduced sleep and appetite because of the headache, but her bladder bowel was normal. Moving on to the examination part, patient was conscious oriented. Blood pressure was 120 by 80 mmHg with no postural drop. Pulse rate was 92 per minute. It was regular. There was no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. There was no acromegaloid features. There were no Cushing's stigmata, no galactorrhea or breast atrophy. She had acanthosis, multiple nevi was present, and JVV was found to be normal. Anthropometry suggested height of 156 centimeters and weight of 72 kg with a BMI of 29.6 kg per meter square with a body surface area of 1.77 meters. On further evaluating the general examination, she had a grade 2 goiter. So on inspection, there was a grade 2 goiter visible with no overlying skin changes or scars or visible pulsations. On palpation, thyroid was palpable, diffusely enlarged with multiple nodules in both lobes. Lower border of the thyroid was not well defined, so it suggested possible retrosternal extension. It was firm in consistency, non-tender, there was no thrill, no palpable lymphadenopathy. On percussion, there was dullness over the sternum, again suggesting intrathoracic extension, and there was no bruit on auscultation. Coming on to the systemic examination, patient central nervous system examination, patient was conscious, alert, oriented. Cranial nerves were grossly normal except the second cranial nerve. The second cranial nerve showed that reduced visual acuity on both sides. As well as on confrontation testing of visual fields, she had field cuts bilaterally on the temporal side, and fundus examination showed blurring of disc margins, but there was no restriction of any extraocular movements. Other cranial nerves were grossly normal. There was no motor deficit or sensory deficit. Reflexes were normal. And other systemic examination, respiratory, CVS, and abdomen were within normal limits. Moving on to the investigations part, she had an 8 AM cortisol of 8.37 microgram per DL and TSH of 0.99 and free T4 of 11.63. And prolactin was slightly elevated with a 44.29 nanogram per ml. IGF-1 was within normal limits. FSH was 20.28, but it was low for her postmenopausal state. Given her 8 AM cortisol being in intermediate range, we went for an ACTH stimulated cortisol, and it was 11 microgram per DL. Her plasma ACTH was 6.91 picogram per ml. Other investigations, including the CVC, was normal. RFT, LFT was grossly normal. She had an HbA1c of 5.2 with the fasting blood sugars of 88. Her electrolyte levels were normal. She had slight derangement in the LDL with 131 milligram per DL. So we came to the impression of secondary adrenal insufficiency with secondary hypogonadism. Since the patient was referred from neurosurgery department, they underwent a MRI, contrast-enhanced MRI brain, and the MRI brain was suggestive of a large, relatively well-defined lobulated midline mass, 5.3 by 5.1 into 4.8 centimeters. It was centered over the clivus and the body of the sphenoid bone. And in the signal characteristics, it was T1 iso-intense with internal hyper-intense foci, likely hemorrhagic, and T2 hypo-intense, no diffusion restrictions in DWI or blooming on SWI. And homogeneous post-contrast enhancement was seen. And about the extensions, superiorly and posteriorly, the cellular mass was compressing the optic chiasma and optic nerves. It was reaching up to, but not beyond the suprasellar cisterns. Anteriorly and inferiorly, it was invading the sphenoid and posterior ethmoid sinuses, clivus, sphenoid bones, and it was narrowing the nasopharyngeal cavities. Laterally, it was involving bilateral cavernous sinuses. It was completely encasing the internal carotid artery, so we can call it an os-fork, and mass effect was seen on the left temporal lobe. The impression was given as pituitary macroadenoma. And since on examination, we found that the patient was having goiter, so on presentation, we underwent a CECT neck and thorax for her thyroid. The thyroid was showing, it was diffusely enlarged, and it was showing multiple hypodense nodules in both lobes with intrathoracic extensions. Largest was measuring 3.4 into 3.1 centimeters in the right lobe. Also, at the same time, CECT thorax was suggestive of multiple lesions in the lungs. A round solid nodule was seen in the lingula, measuring 9 mm. Another tiny nodule was seen in the left lower lobe. Now, since we found that the CECT was suggestive of multiple nodules, we underwent a FNSE thyroid of the FNSE thyroid, and it was showing moderately cellular smears. Cells were arranged in microfollicular and trabecular patterns with scant colloid. Cells showed round to oval nuclei, occasional nuclear overlapping, mild pleomorphisms. Background colloid was sparse, and no nuclear features of papillary thyroid carcinoma was seen, and Hurthal cell changes were not prominent. Since the patient was referred from neurosurgery, they planned to do a transpenoidal biopsy, which was done simultaneously, and it showed tumor tissue composed of follicular structures. It was lined by uniform cuboidal to columnar epithelial cells containing colloid-like eosinophilic materials in the lumen. And these tumor cells exhibited round to oval nuclei with fine chromatin, moderate amount of cytoplasm, no nuclear groups or intranuclear inclusions. There was absence of papillary architectures, and no lymphoid stroma or samoma bodies were present. So diagnosis was given as metastatic follicular carcinoma of thyroid. So our final diagnosis was follicular carcinoma of thyroid with pituitary metastasis, with secondary adrenal insufficiency, with secondary hypogonadism, with lung metastasis. Now, coming...
Yeah, Dr. Abhijit, before the management part, I'd just like to ask you one question as what are the indications for transpenoidal biopsy? Because initially, when you said pituitary adenoma, generally that's not the usual line of management, and why a removal of the tumor was not attempted. So what are the indications for biopsy? Could you just elaborate?
Yes, ma'am. Actually, transpenoidal biopsy is not routine in pituitary masses, ma'am. But in this case, since the mass was mass was not feasible for surgery by the neurosurgeon, they went ahead with a transpenoidal biopsy. In such kind of cases where the mass is not amenable to surgery, we can do a transpenoidal biopsy to get a histological diagnosis, which can help us in planning the further management line. Another is that in case of atypical presentations, we can go for transpenoidal biopsy in cases where the imaging and the hormonal features are discordant. And other than that, midline masses where the diagnosis is unclear, we can go for transpenoidal biopsies.
Okay. Thank you. Now I'd like to, before we go ahead with the management part, I'd like to rope in Dr. Anurag Leela, sir, for this. What would be the differential diagnosis in this case? What are the other things we would have to think of? Of course, here we have come to a definitive diagnosis.
So am I audible? Yeah.
Yes.
Yeah. So this was an interesting case, and so once the thyroid image was shown to us, so we started thinking on lines of pituitary and thyroid masses where they can go together. And most commonly, it will be in a case of acromegaly, where acromegaly do cause multinodular goiter and thyroid swelling, but the features of acromegaly were not there. In cases of McCune, we can have acro as well as goiter, whereas Graves and acromegaly can happen. Shoma can have thyroid shoma, TSH secreting tumors from the pituitary can have a goiter. But again, there were no clues there. And then rare possibilities of Dicer syndrome with pituitary Cushing's. Again, Cushing was not there. With PTCs are known. And last but not the least, yes, metastasis I was thinking, but DI was absent. So absence of DI was not in the favor of the diagnosis which we have reached. And then after, when I've read a systematic review on this, actually the thyroid malignancies are not associated with DI more commonly, and they are like SOL in the pituitary. So the diagnosis of any DTC with the pituitary mets do fit, though it's very, very a rare scenario. So these were the differentials which come into mind. And then the coexisting pituitary tumor, which is more common. It looks like a prolactinoma in this scenario, but the prolactin was normal. And it could be a coexisting thyroid swelling, which would be two swellings, which will be more common. But now here we have turned out, we have connected the dots, and it is FTC causing thyroid swelling as well as the pituitary lesion.
Right. So why is DI less common? Did you find that part like?
No, it would be the way it gets spread to. Maybe it is
Okay.
spreading to the bone and the pituitary area rather
Right.
than the posterior pituitary and the stalk,
Right.
which we have seen commonly with breast and lung and esophageal cancers.
Right. So what are the most common primary sources of pituitary mets? Could you just enumerate, sir?
So like one case per year we see all common malignancies can have unusual presentation. So in my first year of residency, my first patient who was admitted was the esophageal carcinoma with the pituitary mets, which I remember still. And then we have seen breast, lung, colon, all kind of malignancies can have pituitary metastasis, and DI is a prominent feature.
Right. Okay. Thank you, sir, for excellently giving us the differential diagnosis. Now, before we go for the discussion on the management, the diagnosis and management, I would also like to include Dr. Rahman in the discussion here. So the biochemically, we found that the adrenal insufficiency has been mentioned. So how do we diagnose central adrenal insufficiency in such a patient? And could you elaborate on the stimulation testing, ma'am?
Hello. Thank you. Thank you, Dr. Sorbaba. But
Yes.
sorry. First of all, thank you very much for having me. Secondly, amazing case. So I haven't seen metastatic pituitary lesions, and I see a lot of pituitary. It's not like I don't see. And when I saw this presentation, I was literally taken aback when I saw the biopsy report. And that's why I asked you whether it was checked with someone else's, re-reported. So coming to the question, central adrenal insufficiency. So we first of all, going on to the hormonal assessments, there are certain clinical suspicions which should be there. So if there is central adrenal insufficiency, like unlike primary adrenal insufficiency, there will be absence of the hyperpigmentations and the hyperkalemias because the ACTH is not coming, so no hyperpigmentation. For testing, we will be doing the cortisol, which was done here, and that will be either low, less than 3 micrograms per DL, or it can be between the range of 3 to 15, because above 15, it's considered normal. So if it is in the range, is in the gray range, like this patient had in the gray range, then we can go for the stimulation test. So ACTH stimulation test is the test which is it's a gold standard test which we use, but it's not the gold standard test for the central, and there is a reason for that. So what happens is in the stimulation test, what we do is we give them 25 microgram of synactin, the synthetic ACTH by IV or intramuscularly, and then we can measure the cortisol at the baseline at 30 minutes and 60 minutes. So normally what will happen is that the cortisol will go up. It will go up to 18 to 20 microgram per DL. But it will not go up in cases of primary or in cases of secondary, which is the central adrenal insufficiency, only if it is there for a long time. So there has been a time period for the gland to atrophy. If it is not a longer central adrenal insufficiency, then we will not see this, then there might be a response of the cortisol and it might rise. In those cases, the better is to go for the ITT or metoprolol, whichever is available at that time. So here we do see that there is not a good response after giving the cosynotrofin, and as well as we see the ACTH levels, they're also not that very raised. They are also 6, which is for a cortisol of 8, it should have gone up. So yeah, that's how we diagnose the.
Right. Yeah. Thank you, ma'am. Thank you for that explanation. Next, I would like to ask Dr. Anurag, sir, how to proceed with the diagnosis, confirming the diagnosis of a case of metastatic follicular thyroid carcinoma, and what would be the role of the any other markers? Here, the biopsy was done. Any other way we can diagnose such a case, confirm the diagnosis?
So in this case, it's like a differentiated thyroid cancer with follicular, very clear. So in this cases, we don't require IHCs, but when the cases are de-differentiated, anaplastic, and over multiple treatments, when we are not able to recognize the lineage of the tissue, this marker is required, but we can always do it to add on. But in this case, it would be, it will just help us because it's very unusual and it will further confirm that, yes, what we are dealing with. We could have done a PET scan to understand whether the metastasis is elsewhere in the body. FDG PET or a FAPI scan could have recognized the other areas of bony mets, especially with the FTC. And a baseline thyroglobulin can also be very high given the disease burden, which is very obvious. So we know the diagnosis, though those things can be additive, and especially I would do a FDG PET to understand, though they have shown a lung lesion, a small lesion, but there may be many more, much more foci, which may guide us to manage if it is isolated metastasis versus it's a widespread disease.
Right. So I think that was not done because patient was not able to, was not willing for it. So that's what Dr. Abhijit mentioned. I would like to ask Dr. Rahman, so what would be the further plan of management of this patient? What would be the ideal way to proceed with the management?
So first of all, we'll be dealing with the thyroid. So we have to get it out. And then, of course, after taking out, we'll be doing the radioactive iodine therapy. And we will be giving TSH. The second step is the TSH suppression for lifelong. So with levothyroxine and suppressing to TSH, depending on the thyroglobulin and all the levels. But we usually suppress it to less than 0.1 with this kind of size. So, so first line therapy here will be the iodine surgery, followed by the ablation, followed by along with TSH suppression. And then we have to look at the metastasis. So here the metastasis seems to be in pituitary, and as well as something in lung, which also needs to be looked at. So maybe a transthoracic biopsy or something like that, or the scans, PET scans, whatever is possible we can do to find out what exactly that nodule over there in the thyroid, in the neck, in the chest is, in the lungs is. So in case for pituitary, what are we going to do is, it's very rare to have follicular thyroid in pituitary. Again, you can use the targeted therapies and you can use the radioactive iodine therapy for that. And it may help the systemic disease burden and stabilize the intracranial lesion. But there is also a possibility of increase in size and the bleeding inside the tumor. So before that, if the surgeon is willing to do debulk, which is very important, it's a very big tumor. So if he or she can try to take a little bit more out of it, or we can do some radiation therapy and reduce the size and then proceed with the RAI, the ablation therapy. So that's how we have to proceed here.
Right. So how do we know whether they're like radio avid, anything that will?
So we have to radio avid we have to see whether these lesions will take up the iodine or not. That's what we mean by RA avidity. Because if they are not avid, then it's useless to give that. So what we do is there are two ways. You have to make patient hypo. If you give levo, either you stop the levothyroxine and for 4 to 6 weeks and make the patient hypothyroid, or you give a recombinant human TSH, whatever is TSH, if it is available. And you have to raise the TSH to more than 30 m. milli-international units, and you ensure low iodine diet for 2 weeks before the scan. And then you do a diagnostic radioiodine whole body scan, administer a small tracer dose of iodine 123 or iodine 131, and then perform the whole body scintigraphy. And if there is an uptake, so this means this is a radioactive iodine avid disease, and then you can proceed for the therapeutic dosage. And if there's no uptake, then it means that it's a refractory disease, and you have to think of the other options, the TKIs and the radiotherapy and the stereotactic radiotherapy that you have to go through. Yes.
Right. Thank you so much for elaborating that wonderfully, ma'am. Now, I would like to ask Dr. Anurag regarding the newer modalities and with the theranostics so what is the role of lutetium FAPI in this case in thyroid metastatic thyroid
I
carcinomas?
think straightforward, the treatment would have been a thyroid surgery followed by a radioactive iodine. And in this patient is less likely to mount a TSH response on its own. So we have to be ready considering the pituitary metastasis. There would be the thyrotropes may not mount up the response, and we may end up requiring recombinant TSH, specifically in this case. That's one we have, which we have to be specifically pertaining to this case. In other cases, it is optional. And
so do you use it in your regular recombinant?
Not regularly, but yeah, few patients do prefer, and it is available and it is doable. So the nuclear medicine people can use it, and the natural TSH or the recombinant TSH, the response rates are similar, so there's no advantage of one over the other, but that's one option available. Second thing, when I was discussing this case with our nuclear medicine people, what else can be done, as patient was very reluctant for any line of modality in case if the thyroid surgery is not done, because if you go for radioactive iodine, the thyroid surgery becomes a prerequisite. So we were thinking if a FAPI is avid, FAPI is a new form of scan which they do for many, had many indications today for nuclear medicine, and FAPI can be targeted with lutetium and PRRT. So all treatment is palliative. Chemo doesn't work in these cases much. So if patient, so FAPI related lutetium therapy can be done in such a case. We're just thinking aloud, it's not the standard of care, but yes, that can be offered to the patient. And in case it stabilizes the lesion, and then we can plan a surgery or as a new adjuvant therapy, and then plan surgery for future. And some reduction in the size of the tumor, the vision and other things, and the quality of life can remain stable.
Right. Thank you for that. So what to elaborate on what is the role of external beam radiotherapy and what are the possible complications of such therapy? If you could just.
So if it is an isolated metastasis, yes, external RT can be considered here, but how much will it be effective and all, I'm not very sure. And in this case, what we came to know, after starting the radiotherapy, there was some concerns and patient got sick and something like that, and the radiation could not be completed. So which we usually don't see in pituitary adenomas. So that was another unusual response, or maybe again a high dose of steroid is required, or some inflammatory response got triggered post radiation. We are not very sure.
Okay, thank you for that, sir. So now I'd request Dr. Abhijit to elaborate on how this patient was managed. To go back to your slides and.
Coming to the management, initial plan from neurosurgery was to surgically resect the pituitary mass, but they took a decision against surgery as they felt that surgery was not feasible because of the extensive local invasion and there was a risk for significant morbidity. And since they were referring the patient to us, we found out that the patient is having secondary adrenal insufficiency. So we supplemented her with hydrocortisone replacement according to her body surface area, and also planned her for radiotherapy, which she received around 21 fractions of external beam radiotherapy. But unfortunately, the patient deteriorated and was bedridden, and no further palliative therapy could be done as it was not desired by the patient and relatives. And then the plan for the following of the patient clinically and neurologically. Clinically, we wanted to follow up the neurological and endocrine effects of the mass, and we wanted to do interval imaging to see for the growth of the mass, and also periodically reassessing the pituitary axis to see for hypopituitarism.
Right. Okay, so I think because of the time, we will conclude with the case. I thank the panelists. Any few comments, any further comments from any of the panelists would like to, Dr. Rahman and Dr. Anurag sir, any more concluding remarks regarding the case?
We're good. We have discussed most of it, I guess.
Right.
It's a rare scenario.
It is a learning point for me. I came to know about something which I haven't seen. So yeah, I had gone through literature about it and I found out there are particular 20 to 25 cases all over the world reported till now of thyroid cancers in pituitary gland. So yeah, it was good presentation and a good learning point for me. Thank you.
Yeah, thank you so much for having this discussion, and over to Dr. Achini to wind up this.
Dr. Uma.
Dr. Uma.
Thank you, Saurabha, and
Yeah,
all the panelists. So now we go on to the last part of this session, that is the answers to the quiz. And I request Dr. Rashi to do the name.
So Rashi will be answering 15 quiz answers, 5 the pre-conference. Yeah, perfect. So it'll be 15. So you have to be patient with her. Go ahead.
Yeah, so let's begin with the answers and the results of the pre-conference quiz followed by the live quiz. The first question in the pre-conference quiz was a 52-year-old woman incidentally found to have a 9mm pituitary lesion on MRI is asymptomatic. According to 2025 Pituitary Society consensus, what is the most appropriate next step? And the options were immediate transsphenoidal surgery. Second was B, was visual field testing and pituitary hormone evaluation. Option C was no further follow-up is required, and option D was empirical dopamine agonist therapy. And the correct answer is option B. And the reference is the latest guidelines of Pituitary Society on incidentalloma, which says that there should be a hormonal evaluation in all cases of pituitary incidentalloma at initial presentation, irrespective of size, and a visual testing to be ordered in a smaller lesion less than 10 millimeters if it is close to the optic chiasm. And then proceeding to the next question. For an aggressive metastatic pituitary carcinoma not responding to surgery and radiotherapy, the recent European Society of Endocrinology recommendations support the use of somatostatin analogs only, ketoconazole, temozolomide, cabergoline. And the answer is temozolomide, and it has been taken from the latest European Society of Endocrinology guidelines on the management of aggressive pituitary tumors. In next question. In girls with central precocious puberty, radiomic analysis of pituitary MRI demonstrated each of the following findings. This is low pituitary volume compared to controls, a high receiver operating curve, area under the curve of 0.81 using the shape, features, and grayscale non-uniformity, perfect predictive accuracy of 1, and no correlation with LH levels. And the correct answer is option B, high receiver operating curve, area under the curve of 0.81 using shape, features, and grace level non-uniformity. This was a recent study. Basically, radiomic analysis of pituitary MRI in girls with central precocious puberty is an emerging technique that uses machine learning to extract quantitative features from MRI scans to aid in diagnosis and distinguish CPP from other conditions. And this was a latest study published in Frontiers in the year 2025, which found this analysis. In recurrent autoimmune hypophysitis, not resistant to corticosteroids, which additional therapy has not been used successfully? And the options were methotrexate, rituximab, cabergoline, and azathioprine. And the answer is cabergoline because all the others are non-glucocorticoid immunosuppressives which can be used in patients vis-a-vis cabergoline, which is a dopamine agonist and has no role in management of autoimmune hypophysitis, as in the inflammation part of it. Going to the question 5, in adult onset empty cellular syndrome, recent research suggests frequent endocrine dysfunction requiring evaluation. Option B, always normal pituitary function. Option C, the imaging is unnecessary in these cases and that empty cellular always indicates a tumor. And the correct answer is frequent endocrine dysfunction requiring evaluation. And this again has been taken from the Pituitary Society Incidentaloma Guidelines of 2025 for evaluation of incidentaloma, where hypopituitarism rates were considerably higher in patients with empty cellular syndrome, based on clinical suspicion and in those diagnosed incidentally. And the winners of the quiz are Dr. Shubhankar, followed by second place goes to Dr. Arundhati Das, and the third place goes to Dr. Kirtiman Mandal. I congratulate all the winners for a resounding success. Now let's proceed with the live quiz. Yeah. So let us go to question 1. Can I see the slides, please? Yeah. So which among these is not a PIT1 lineage pituitary neuroendocrine tumor? And the correct answer is option D, that is corticotroph tumor. And this is as per the classification of World Health Organization 2022 of pituitary neuroendocrine tumors. So this corticotroph tumor is a TPIT lineage tumor. Then going to a 36-year-old woman with ACTH-dependent hypercortisolism undergoes IPSS with desmopressin stimulation results. And the correct answer to this question is option B, that is true left-sided corticotroph microadenoma with anomalous venous drainage. So here the MRI was showing a 6 mm lesion in the pituitary, but the IPSS results were pointing to a right-sided lesion. However, it is strongly recommended by the guidelines which were published for Cushing syndrome in JCEM in the year 2015 that IPSS should not be relied upon for lateralization due to anomalous venous drainage. And this question was actually hinting towards that. Going to question number 3. Which of the following MRI techniques has recently shown greatest improvement in differentiating preoperative Rathke's cleft cyst from cystic pituitary adenomas? And the answer is option B, diffusion-weighted imaging. So preoperative diffusion-weighted imaging evaluates cystic pituitary lesions by analyzing water diffusion within the tissue using apparent diffusion coefficient to predict tumor consistency and aid in surgical planning. So a lower ADC value often indicates high cellularity and firmness, while a high ADC value suggests softer and more easily resectable tissues, helping surgeons in preoperative planning. Going to the next question. In immune checkpoint inhibitor-induced hypophysitis, which pituitary hormone deficiency most commonly precedes others? And the correct answer is option A, ACTH deficiency. And this has been taken from the article, basically hypophysitis secondary to immune checkpoint inhibitors therapy, clinical presentation and long-term outcomes, published in the year 2016 by JCEM. Going to the next, in evaluation of suspected Cushing's disease, recent advances in functional imaging include the following tracers of PET scan, and the correct answer is 11C methionine. And this has been repeatedly discussed, and it is even in the latest publication of January 2025 in JCEM, there is the importance given to 11C methionine beyond the routine imaging in Cushing's disease. Going to the next question. A patient with long-standing partial central DI is admitted with sepsis and develops confusion and her serum sodium is 124 millimoles per liter. What is the most likely reason for hyponatremia? And the option is option C, over replacement with desmopressin and excess free water intake. As was discussed even in today's class, there is a high chance of developing hyponatremia for patients who are on desmopressin therapy. So yes, this is taken from the standard Williams textbook from the chapter Disorders of Water Balance. In patients on pegmesomant therapy for acromegaly, which of the following requires most frequent monitoring? And the answer is actually liver function test, as pegmesomant is a relatively hepatotoxic drug, and almost monthly monitoring is required for the first 6 months, and the treatment is discontinued if the transaminase levels are more than 3 times the upper limit of normal. Going to question 8. A woman with microprolactinoma desires pregnancy and she's on cabergoline 0.5 mg per week with normalized prolactin and regular cycles. What is the best approach? And the answer is option B, discontinue cabergoline once pregnancy is confirmed. So this is again published as management of prolactinoma during pregnancy. And we know that this is a microprolactinoma. If it was a macroprolactinoma, then the management would have been different. But since it's a microprolactinoma with normalized prolactin values and regular cycles, cabergoline can be safely discontinued during pregnancy. Going to question number 9. Which of the following emerging biomarkers in cerebrospinal fluid is under investigation as a diagnostic tool for autoimmune hypophysitis? And the correct option is option B, that is intrathecal antipituitary antibodies. So antipituitary antibodies are a marker, especially of autoimmunity in pituitary gland. So that is why this can be raised in patients of suspected autoimmune hypophysitis. Going to option number D. This is a 16-year-old boy who presented with features of panhypopituitarism, and the MRI brain was suggestive of pituitary stalk interaction syndrome. And the correct answer is option C, that is genetic mutations in PROP1, HES-X1, and LHX4, which have been implicated in familial cases. And we do know that this is a congenital disorder of basically pituitary development, and about 5% of these cases have a genetic linkage or identified genes which are mentioned here in this option number C. So this brings us to the end of the live quiz questions, and now it's time for knowing the winners of this session. And the winners are, the first prize goes to Dr. Deblina Paul, the second goes to Dr. Ayush Agrawal, and third prize goes to Dr. Halar Rahim. I once again congratulate all the winners for attending this quiz and making it a big success. Thank you, one and all.
Thank you, Rashi. So we've come to the end of today's session. It was a learning experience for me. I learned so many new things. And thank you, Sarita ma'am, and Dr. Faria for this. And now I hand over the mic to both of you for the concluding remarks.
Faria?
Okay. Thank you. Thank you, Dr. Uma, for conducting the session wonderfully. Thank you, all the moderators, the speakers especially, for brilliantly briefing the cases, and the panel of discussants for discussion of the two important cases of pituitary. And of course, the quiz master brilliantly conducted the quiz session. So thank you all, and it is a great pleasure for me to hear the pituitary session, and I enjoyed and learned a lot. Thank you. Over to Sarita madam.
Yeah, so perfect. So you can see the calendar. Already we have the convener with us, Dr. Amit Shakya, who's the president of DEAN at the moment. And he will be the convener for the next program on the 11th of December. Again, it is a Thursday. And so Nepal is going to be the host. And you can see the lineup of the subsequent meetings as well. So as you can see, we've come to a close. And I think I must congratulate everybody because we're still 1 minute to go. So I think exactly 1 minute, I will stop talking as well. And it's a real privilege to thank all of you. Faria plays multiple roles, but I think women are very good at multitasking. So not only is she the patron, she is the president, She's also chaired the session today, and she's been around. Thank you, Faria. You're a very, very good pillar of support for me.
Thank you.
Uma and I have started plotting and planning as to which system and cases. And I think, Uma, you've done a wonderful job, as well as your presenters, both Surya Narayan and Abhijit. So hats off to you for the excellent cases that were selected.
Thank you, ma'am.
And Rashi, the quiz was brilliant. And I really like the explanations also, because I think that is so much more important, because a quiz is a very, very important part of learning. So Uma has had
Thank you,
to,
ma'am. Thank you so much.
Uma's had to play a double role again today because she took over from Sahana. Thank you, Uma, apart from being the convener. Parth and Saurabha, the moderation, the questions, I think excellently fielded. And thank you, Amit. Thank you, Anurag. Thank you, Inuruz, for the answers that you gave and the explanations. Very, very clear, concise, and crisp. And of course, congratulations to the winners, all the winners. They will all be getting certificates. In fact, all of you will be getting certificates as well. And thank you to the tech team. Thank you very much. Thank you. So good night. Looking forward to seeing you for the next program.
Thank you, ma'am.
And so Amit,
Thank
a
you,
lot of
ma'am.
hard
Good
work
night.
for you.
Oh, thank you and good night, everyone.
Good night.
Thank you, madam. Thank you. Good night.
Thank you, ma'am, and
you, madam.
good night, everyone.
Thank you. Good night.
Right.
Tech team, please close the session.